Thank you very much for that warm welcome. It's an honor and a privilege to stand before you. And I would like to thank Dr. Nema for and the committee for allowing me this opportunity to share my experience with all the colleagues. So basically, I'm just going to share for me where the first two cases that happened in my basically that I came across. They always say they come in threes, so I'm still waiting for the third patient. So this way basically to highlight because I actually manage them, co-manage these patients, the general surgeon who was actually very shocked that actually endometriosis is a cause of intestinal obstruction. So he said he was going to redo his slides now and put endometriosis as number 2 of small bowel obstruction or enlarged bowel obstruction when he lectures at the university. So basically just running through the literature that it actually is a rare cause of intestinal obstruction, and accounting for less than 1% of all cases. One of the problems is just the symptoms are very non-specific and they can carry on for a long time. And most of these patients also struggle with chronic pelvic pain, dysmenorrhea, dyspareunia. So you actually may not even recognize that they have this problem. And the most common questions that we see is obviously stage 4 endometriosis, where it involves the rectal sigmoid, the rectum, the appendix, and also the terminal ileum, and then the cecum. It rarely affects the transverse colon. So I would like to present the first case. Was a 37-year-old nulliparous patient with primary infertility since 2010. And she had dysmenorrhea, visual annual analog scale of 9 out of 10. And she had a cyclic bleeding from the umbilicus. She had rectal bleeding, sharp rectal bleeding, constipation, malaise, and vomiting, and what she basically described as brain fog. Clinically, you could see the big umbilical nodule, and also she had tenderness in the posterior fornix, especially on the left side. On the transvaginal sonar, we saw 2 bilateral endometriomas, a small fibroid, and also a nodule, a rectal cervical nodule. In terms of endometriosis, rectal cervical nodule is more common than rectal vaginal endometriosis. So basically she was cancelled for laparoscopy for, basically if you see endometriomas that are bilateral and a nodule, in most cases there's obviously bowel involvement, so there's obviously going to be a frozen pelvis. So basically we discussed the option that if we find the appendix involved, we'll then take it out. And then at laparoscopy, I was found definitely the frozen pelvis, and I think the only thing we could see was a small fibroid. You could not even see where the uterus was, because the whole bowel was actually on top of the uterus. There was also endometriosis of the appendix. There was endometriosis of the diaphragm, more on the left side. I'll show you the picture. Then we did the surgery. And then post-operatively, she was not passing any flatus. And she was not throwing up. The abdomen was soft. It was not distending. And then she kept on complaining of right-sided chest pain post-operatively, which we assumed to be because of the atelectasis from the surgeon, from the general anesthetic. And then, but despite the physiotherapy, we then ended up doing a chest X-ray and a CT scan, which showed that she had, initially they were convinced that it was pneumothorax, a pleural effusion, and then there was also air. And then she did not pass stools for about 4 days, and then she was not improving despite giving her laxatives and all that. So we then ordered a CT scan which showed the right pneumothorax and also large bowel obstruction. So that was on day 4 post-operatively. And also she had a fistula, ureteric fistula on the left side, most likely from avascular necrosis, rather than the femoral injury. Because normally we're using a scissors in that area. So the patient underwent basically this resection of the nodule that we'd actually probably missed, because preoperatively we did not do an MRI scan. We didn't know the extent of the nodule. So we removed part of the nodule, but obviously the other nodule that was there, because of the post-operative edema, she then developed a complete bowel obstruction. So she had a sigmoid resection with a colostomy and then left ureteric reimplantation. So I would like to, this one. Okay, I want to play the first one. How do I play the first one? This one. The first video. I put it. No, not that one. Sorry for that. So normally what I do is this one. I will do that one. No, one at a time. One is to do this one. So I normally use the Verez needle for entry, and then I use create the pneumoperitoneum, and then I use a visual entry, a visual cannula. So basically, because she had a nodule around the umbilicus, we could not actually go through the umbilicus, so we went in the midline about 3 centimeters above, and then we looked down. We did not see the nodule. It's intra-abdominally, and then when we get the focus, then you'll see that this is just basically small intestines, and then we then look around the liver. You could see the endometriosis nodules there, and then so that was and then there. And then we go to the other side. This is where I was actually more worried. She had endometriosis there, and you could see the diaphragm there is very thin. So I was actually more worried that she would have a spontaneous, no, the first one. If you can play it fast, then maybe it's better. Maybe go to the halfway. So basically, you could see there that's the bladder is down there, and that's almost like the urachus. So where the bladder was actually stuck, and below this bowel is the uterus, and then I think you can see the fimbria on that side. So basically, it's one of those things that you see that she had a frozen pelvis, and then obviously they say there's always a way to unravel this madness. You always start that white line of Tolt on the left side. So you go higher up and basically release the sigmoid colon as you try to actually go down to eventually late faster. So most of the surgery I just use monopolar and bipolar. And then maybe we can go to the second slide. Next time I have. So you can see here the appendix here is actually stuck. This is the right shoe. So basically the appendix is actually stuck there and it's actually twisted. And then I think towards the end of this, if you go to, so basically you use the push and spread techniques. You use traction and counter traction, poke and spread technique to try to open the spaces. Because also the anatomy, if you go retroperitoneal, it's actually unviolated, so you will be able to actually dissect most of this thing. So the whole thing is that you start on the left side, the bowel, and then I usually use a Surgisal, a hemostatic agent to reduce the oozing. Because one of the problems with surgery in endometriosis is the constant ooze. These patients ooze for a long time because of the chronic inflammation that is going on. And then basically it was just to try and release the appendix. So the cecum is here. I think if we actually go, there is the cecum. And then eventually I found that this appendix was actually a bit twisted. And I think, and in retrospect, I think I should have actually explored the terminal ileum. If you look at into one of the slides where we were saying that it's rare to be in the terminal ileum, so it's usually the appendix. So you assume that once you see endometriosis in the appendix, then that is it. If you can go to number 14 minutes on the slide. But basically, eventually we managed to find this is the uterus there. But I then separated then I did an appendicectomy on this patient on that side, on the right side. After I mobilized it, I then removed the appendix. So that was the first patient with a large bowel obstruction, and then the other patient was a 35-year-old nulliparous patient with primary infertility. She had been diagnosed previously with stage 4 endometriosis, and they done a laparoscopy in 2010 initially, and then later on in 2022. Where they basically found it was a frozen pelvis, and they just operated. They just couldn't. They tried to do a laparotomy, and obviously they abandoned the procedure. And she was supposed to go and see one of the endometriosis specialists, but then she then presented acutely with severe pain. So on the MRI scan, we found that she had bilateral endometriomas, and then we was also cancelled for laparoscopy for frozen pelvis and possible endometriosis. So basically, what we then also found in this patient, and obviously too, we ended up with we found that she had a small bowel obstruction at the terminal ileum, and then did the right hemicolectomy and a small bowel excision with ileocolonic anastomosis. She had no ureteric injuries, and now. So basically, this is one of the things that we found that you could see. This is the bladder. She had a previous laparotomy scar there where there were adhesions, and then basically I just filled up the bladder with methylene blue so that I could then dissect the bladder, because one of the major problems was how do you approach a frozen pelvis? You should actually start away from the pathology. So most of the time you can actually open the paravesical, medium and lateral paravesical spaces, and then proceed. I think I'm running out of time. Basically, these were the histology reports, where basically they confirmed that actually there was endometriosis, and then remember someone was talking about the diagnosis of the pathologist. So with this laboratory service, they routinely do CT staining. So it's no longer that you think you look for stroma and glands. You should do CT staining to diagnose more endometriosis, because the frustrating thing is you find that you diagnose, you see that it looks like endometriosis. The histology comes back as fibrosis. So what do you tell the patient? She has fibrosis with endometriosis. But if you actually find most of the patients, when they do histochemistry, you find that actually the report always then confirms. So this is the bowel obstruction, because what he did the right hemicolectomy, and then joined, I think there was skipped lesion on the small bowel as well. So we had to take about maybe 20 centimeters of the small bowel, besides the terminal ileum. We had to take, because there were skipped lesions on the bowel as well, on the small bowel. So then she did well in ICU and started fast stool and flatters. And then was discharged, I think, on day 5 post surgery. So basically the main thing is that it's difficult to diagnose this, and you also need a surgeon. Because one of the things that whilst we were doing this surgery, the surgeon saw lymph nodes, the retroperitoneal lymph nodes, and his diagnosis was, he thought it was cancer. So endometriosis does cause retroperitoneal lymph nodes. So he also learned 1 or 2 things about that. And then he should have managed it as endometriosis. Those are the references. Thank you for your attention.